One. Good afternoon. It's Dr. John Bennett from Miami Beach, the studio of Neurosurgical TV. We have another in the weekly Africa Neurosurgery Grand Rounds. And today we're graced with the presence of Nathalie Gumsi, who we're watching grow up on this channel. She was a student and she attended these conferences, and now she's a resident at the Ivory Coast. Before we turn it over to Nathalie, let's meet the panelists. Hello, Zolo.
Hello, Dr. Ben. Hello, everybody. I am Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon. I'm a member of Afan, Association of Future African Neurosurgeons, and I'm happy to be here today. Thank you.
Very good, Zolo, a vital member of this team. Hello, Marco.
Hello, guys. My name is Marco Meroni. I'm a consultant neurosurgeon in North Italy. Nice to see you again.
Okay, welcome, Marco. Dr. Gubullo, are you there? You may have stepped away. Oh, go ahead, Dr. Gubullo.
Hello, everyone. My name is Kabulo. I'm a resident in neurosurgery at the University of Zimbabwe.
Yeah, like Marco, a frequent visitor to this channel. Regis, are you there? Go ahead,
yeah,
Regis.
I'm here. Yeah, I'm here.
Go ahead, Regis.
Okay, hello everyone. So my name is Regis Takokam, resident in neurosurgery in Ivory Coast. So it's my first year. It's good. It's good to be here a new time for another session. So nice to meet you all.
Okay, welcome, Regis. Okay, Nathalie, welcome, and it's all yours.
Hello everyone, I'm Nathalie Gumsi. I'm a resident PGY1 neurosurgery in Abidjan. So today we are going to present on the emergency management of brain tumors. So let me just share my screen. Okay. I hope everybody can see.
Yes, we can see it well.
Okay, so as I said, today we are going to present on emergency management of brain tumors. So as introduction, we'll say that patients with brain tumors, excuse me, okay, patients with brain tumors and systemic malignancies are subject to diverse neurologic complications that require urgent evaluation and treatment. And it is essential for neurocritical care professionals to recognize and appropriately treat common oncologic emergencies associated with these malignancies. These complications are usually a result of either a direct effect of the brain tumor on the central nervous system and indirect complications of various treatment modalities. So the prompt diagnosis and timely management may preserve neurologic functions and may even be life-saving. We will start by describing the different direct effects of brain tumor on the CNS. The first and the most frequent complication is an increase in intracranial pressure, which is usually due to cerebral edema. This is as a consequence of an expanding mass lesion associated with cerebral edema. Hence, there are prominent features of high-grade primary brain tumors such as glioblastomas and sometimes meningiomas. These brain edemas are most often vasogenic rather than cytotoxic, and the etiologies are variable. The first being the presence of vascular endothelial growth factor, which plays a key role in tumor angiogenesis and vasogenic edema formation. This VGF will also compromise the blood-brain barrier, resulting in free leakage into the surrounding brain. This VGF may also impair the function of occludin, induce a fenestration of endothelial of the endothelium, and lead to synthesis of and release of nitric oxide, which is participates in the opening of the tight junctions and enhances the capillary permeability. So on this image, we have a T2 MRI of an axial cut of a cerebral MRI, which shows you can see the edema. This is the tumor, and the edema all around. You can see that there's even a herniation, an oncal herniation, and there's a deviation of the midline. There's a midline shift. This vasogenic edema could also be due to radiotherapy. So we have two cases here. We can have a pseudo-progressive edema, which usually spontaneously decreases in few weeks, or these radiations will also lead to vascular damage and hence radiation necrosis. And usually the edema resolves much more lately. This edema could also be cytotoxic. It is usually due to status epilepticus, meningoencephalitis, hyperammonemia, or stroke. A decrease in CSF outflow could also cause brain edema by vascular obstruction or decrease in CSF absorption. This edema also could be caused by the presence of intratumoral hemorrhage. The clinical signs are usually that of an increased intracranial pressure, that's headache, vomiting, nausea, papilledema, etc. And we could also have a Cushing reflex. A Cushing reflex is a triad which associates hypertension, bradycardia, and also dyspnea. Usually, when you have this Cushing reflex, it signs that there's a the need to promptly act in order to reduce the mortality. So on this image, we have a brain scan on the axial cut, which shows a hydrocephalus, and we can see that there's edema around there's effusion, there's effusion of liquid towards the parenchyma around the hydrocephalus. This is an obstructive hydrocephalus. The treatment of brain edema are variable, but the main aim is to decrease the intracranial pressure. Usually, we start by general measures like head elevations 30 to 40 degrees to 45 degrees above the trunk, or hyperventilation with hyperventilation to increase the partial pressure of CO2 to 26 to 30 millimeters mercury. Actually, when you have a hyperventilation, it will lead to a vasoconstriction of the vessel and hence decreasing the cerebral blood volume. Next, what we can do is that we can use medical therapy. We can start by osmotherapy, where we can use whereby hyperosmolar agents such as hypertonic saline or mannitol create an osmotic gradient that draws water across an intact blood-brain barrier to a higher osmolarity of blood. So we can use, as I said, hypertonic saline at 3 to 23.4% concentration, or we can even use mannitol. Secondly, if that doesn't work, we can also use corticosteroids. The main corticosteroid recommended is dexamethasone, where we start by a loading dose of 10 to 20 milligrams, and then we shall give a daily dose of 8 to 16 milligrams, where that will be divided into 4 doses per day. Usually, we have a benefit here within 24 to 72 hours. And lastly, we can use an inhibitor of vascular endothelial growth factor, which is bevacizumab. This is usually done not emergently, because could be done lately to reduce vasogenic edema. If all these medical methods doesn't work, we can revert to do amongst the first, a tumor debulking is a procedure whereby a surgically incurable malignant neoplasm. Please, can you get me all? I think my net is unstable. Can you hear me?
Yeah, it's okay for me.
Okay, thank you. Tumor debulking is a procedure whereby surgically incurable malignant neoplasm is partially removed without curative intentions. It could be done in order to make subsequent therapy with drugs, radiations, or to ameliorate the length of survival of the patient. It could also be brought to do an evacuation of the hematoma if you have an intracranial hemorrhage. We could also be able to do ventriculostomy in case of obstructive hydrocephalus, as we said. But we have to know that patients with glioblastomas usually benefit from gross total resection alongside with radiotherapy and the use of temozolomide as chemotherapy usually improves the overall survival, but this is not done in an emergency. The second direct effect of cancer on the CNS is usually epilepsy or status epilepticus. It is a frequent complication of primary and metastatic brain tumors. It usually occurs early in the course of the disease, and it is the risk of its occurrence is usually inversely proportional to the grading of the tumor. In contrast, tumors associated status epilepticus most often arises later in the course and may indicate tumor progression. The administration of anti-epileptic drugs is usually there's usually a poor penetration of anti-epileptic drugs into the epileptogenic lesions. This is usually secondary to the expression of multi-drug resistant proteins by the tumor, or the tumor may interact with concomitant chemotherapeutic agents used in the treatment of high-grade tumors. Most commonly, the patients with glioneural malignancies such as dysamblyoplastic neuroepithelial tumors and gangliomas, or diffuse low-grade gliomas and glioblastomas will manifest either a status epilepticus or epilepsis. Among the patients with low-grade gliomas, those with oligodendrogliomas and the oligoastrocytomas are more prone to develop seizures than those with astrocytomas. This is due to the more cortical and the later. We have to note that this state is usually rare in patients who have brain metastasis. The tumors, patients who have these states or epilepsy, who manifest with epilepsies with seizures, are usually patients who have tumors which are located in epileptogenic areas such as the mesial temporal lobe, the insula on the cortex. Some molecules have been incriminated with patients who manifest seizures. Manifest seizures in their tumors, with their tumors. We have isocitrate dehydrogenase 1 and 2, which are driver mutations in low-grade gliomas and are reported to be associated with an increased risk of seizures. So studies made on low-grade gliomas, we found that there was this IDH with a high prevalence or high incidence or prevalence of seizures in these patients. Glutamate has also been incriminated, as well as GABA, as well as GABA. As for the treatment, we realized it is being realized that older generation anti-epileptic drugs such as phenobarbital, phenytoin, and carbamazepine induce cytochrome P450 enzymes, which can accelerate the metabolisms of common chemotherapeutic agents and decrease their effectiveness, Hence, newer anti-epileptic drugs, including levetiracetam, lamotrigine, and lacosamide, are preferred due to the low probability of pharmacokinetic interactions and a more favorable tolerability profile. We have to note that anti-epileptic drugs resistance seems to be directly proportional to the tumor grade. The higher the tumor grade, the higher the resistance. Finally, we have a direct effect. We have leptomeningeal metastasis. This is a rare but debilitating complication of malignancy with dissemination of the cancer cells in the to the CS to the whole of the cerebrospinal fluid. It can also disseminate to the pia and the arachnoid matters. It represents 1 to 2% of patients with primary brain tumors, such as high-grade gliomas, medulloblastomas, ependymoma, and the pineoblastomas. The spread of these cells, of these malignant cells, could be either hematogenous, it could be at a direct extension, it could be a direct extension, it could also spread to the choroid plexus, or a retrograde invasion along the perineural or perivascular space. The clinical presentations of leptomeningeal metastasis is really varied. So there's no clear presentation for this pathology. It usually can manifest by simple headache up to seizures. We could also have cranial neuropathies associated. But on the MRI, the leptomeningeal metastasis will manifest as you can see on the, let me take care. As we can see on the MRI, on the right, we have linear or nodular enhancement of the cerebral sulci, the cerebellar folia, the basal system, as you can see here on the optochiasmatic system. In the optochiasmatic system, it can also be invade the subependymal, the cranial and the spinal nerves. It can also cause hydrocephalus. So according to the National Cancer, excuse me, please. According to the NCCN guideline, the presence of any of the following is sufficient to diagnose leptomeningeal metastasis. If the patient has positive CSF cytology, positive radiologic findings with supportive clinical findings consistent with leptomeningeal disease, signs and symptoms of consistent with leptomeningeal disease, or non-specific but abnormal CSF studies. As we said, these are the nodular enhancement of the different sulci. So this patient is having a leptomeningeal metastasis. We can see linear enhancement of the different cisterns, and here the patient is having hydrocephalus. So now the dilemma is, whom should we treat aggressively? Whom should we treat aggressively, and whom should we just treat non-aggressively? So the NCCN said found out that patients who should be treated aggressively are patients with low tumor burdens, good functional performance status, lack of major neurologic deficit, no evidence of bulky disease on imaging studies, the absence of CSF flow block using radioisotope imaging, and expected survival greater than 3 months, and limited extraneurial metastatic disease. The aim of the treatment here is to improve and stabilize the neurologic functions, to maintain the quality of life and possibly extend survival. So here we can use, the treatment could use radiotherapy, systemic chemotherapy, and intrathecal chemotherapy. We have to note that methotrexate, cytarabine, longer-acting liposomal cytarabine, and tiotepa improve or stabilize the neurologic functions, maintain quality of life, and possibly extend survival. But methotrexate, cytarabine, tiotepa, and temozolomide achieve cytotoxic CSF concentration when given at high doses, although they cross the blood-brain barrier. Hence, if administered, it's an intrathecal delivery will reduce the overall dosage of these molecules, and hence reduce the adverse effects of these molecules. Now let's pass to the indirect complications. The indirect complications are grouped in two ground groups. We have the cerebrovascular diseases and the infectious diseases. The cerebrovascular diseases represent 15% of the complication of brain tumor complications. In most intracranial hemorrhage is the most common form of stroke in patients with hematologic malignancies, while there is an approximately even distribution of ICH and ischemic stroke with solid tumors. The infarction here, first let's talk about the infarction or ischemic stroke. It is usually due to compression or necrosis of intracranial blood vessels, intravascular embolization by the tumor, hypercoagulability via tumor production of mucin, leading to formation of platelet-rich thrombi, release of procoagulant molecules such as tissue factor, cancer procoagulant cytokines such as tumor necrosis factor alpha, interleukin 1 and 6, and also due to hyperviscosity leading to obstruction of small end vessels. The second type of disease is which is the most common, is hemorrhagic stroke. This is usually due to tumoral hemorrhagic conversion. It is most frequent in glioblastomas and in brain metastasis. Here we can see an image on this T1 MRI, weighted MRI, where we can see the hemorrhage as this hyper intense image at the center of the tumor. At the center of the tumor, we can see that there's a voluminous hematoma around the tumor, and there's even a midline shift already. We can't even see the frontal, the anterior horns of the lateral ventricles. Lastly, these patients are also subjected to cerebral venous thrombosis. It can occur as a consequence of hypercoagulability or by direct compression or invasion of the cerebral cyanosis from the dura or calvarial metastasis and the meningioma. So this is these two images we have. On the first, we have the brain scan, and on enhanced brain scan, where we can see a tumor, a parietal tumor. It's a parietal tumor, yes, which is with a hemorrhage inside the tumor, and you can see there's a large zone of edema and the midline shift. Same here with this T2 weighted MRI image. You can see an intratumoral hemorrhage. So lastly, patients could be also with pituitary adenoma could be subjected to an hemorrhage or infarction in the pituitary adenoma. This is usually called pituitary apoplexy. This is a rare but potentially life-threatening complications. So the clinical presentations of patients with cerebrovascular disease are usually those of a usual stroke patient. Usually, this can also lead to brain edema, leading to increase in intracranial. They also come with signs of encephalopathy or multifocal cerebral infarcts. As for patients with pituitary apoplexy, usually, the patient will present with a sudden or brutal visual field or acuity defect. This is an emergency, or this usually a surgical emergency. So on this table, we are trying to summarize the different vascular events, the different causes, the mechanisms, and the associated malignancy. What I encircle are those which are brain malignancy, which will lead to these different complications. So we can see here that for hemorrhagic stroke, we usually find it mainly in, as I said earlier, in glioblastomas and brain metastasis. The management, as for the management of these patients, for ischemic stroke, the role of antiplatelet agents is in secondary prevention for cancer-related stroke remains really uncertain, so it's not really used. But they prefer the use of low molecular weight heparin product over warfarin due to the better bioavailability, and it has a longer life, and there's no drug-to-drug interaction. As for the treatment of intratumoral hemorrhages, it depends. It usually depends on different factors. That's the size and the site of the hemorrhage, the clinical status of the patient, and the presence of coagulability. But lastly, we shall talk about the infections. It is usually an important cause of neurologic morbidity and mortality in patients with cancer in general and brain cancer. There's an increased susceptibility in cancer patients due to the immunologic their immunologic status being compromised by either the malignancy or the treatment that they receive. The spread of these infections could be either hematogenous, either metastasis from focal infections, or direct extensions from surrounding structures. So usually in brain tumors, this is the main method of spread. That's direct extensions. The patient usually have some risk factors. That's a patient usually who presents with will present usually with a neutropenia less than 500 per millimeters cube, secondary to intensive chemotherapy, or the patient could even present with a bone marrow invasion. Usually, if there's a bone marrow invasion or aplasia, you have a high risk of having bacterial or fungal infections. So on this table, we tried to summarize the different germs, the different bacteria, fungi, viruses which could be encountered in head tumors as a complication of a head tumor, a brain tumor, sorry. So we can see that Staphylococcus is usually associated with head tumors, and this is the main treatment. Also with patients with VPtions, since Staphylococcus aureus is usually an ubiquitary germ. We can also have Cryptococcus neoformans, which is usually associated with patients who have a diminished immunologic status due to chronic steroid use, or even Candida albicans or Epstein-Barr virus. So to conclude, I would say that neuro-oncologic emergencies are relatively common in patients with cancer and associated with significant morbidity and mortality. The high index of suspicion is often needed. A high index of suspicion is often needed to make diagnoses such as increase in intracranial pressure, hydrocephalus, subclinical seizures, meningitis, or venous sinus thrombosis. The rapid recognition and proper treatment can prolong the patient's life and improve functional status and his quality of life. So lastly, I will finish by this slide to say thank you all, and please protect yourself during this pandemic of coronavirus. This is Amari Francis. Thank you.
Very good. Thank you very much, Natalie. Excellent and a good quality slides and presentation. Okay, we'll talk about later how you have to use the technology of that pointer. That was excellent. That's the first time I've seen it. We'll talk about that later. Anyways, I'd like to greet Carlos. Hello, Carlos. Carlos is a big neurosurgeon from Barcelona, or Madrid, I'm sorry, in Ecuador. Hello, Carlos, are you there?
Hello. Good afternoon for everybody.
Hello, Carlos.
Good afternoon. Good
Yes,
afternoon, sir.
Yes. Any questions or comments for Natalie? Anybody? Don't leave me hanging. Marco, any comments or questions?
Hey, First of all, my best congratulations for Natalie. It's very exhaustive. I appreciate a lot how you focalized also about infection in patients with brain tumor. I want to highlight the importance of surveillance of antipyretic drugs because I have experience of patients when use valproic acid, and in these patients, sometimes you see a deterioration. Pay attention to check for ammonemia, because in these patients you can have some deterioration caused by valproic acid, but it's not related to the tumor, but to the anti-epileptic drugs. So check the ammonemia, and you see there is a hyperammonemia. So pay attention to this.
Thank you. Thank you. Any comments? Regis, we haven't met you. How you doing? You want to introduce yourself there, Regis?
No. Today, no. Everything is okay for me. Thank you, Natalie, for the presentation. It's all.
Okay, where are you from, Regis? Are you from Cameroon also?
Yeah, John. I'm coming from Cameroon. I'm a member of Afan too. The last time I present myself, so I thought you remind.
But Regis, there may be 1 or 2 people watching that may want to know who you are. Hopefully, it's not a private conversation. Okay, Zolo, any comments or questions for Natalie?
Question, no. The only comment is that it was a wonderful presentation. Thank you very much, Dr. Natalie, for the quality of the presentation, and it was really an interesting moment.
Very good, thank you, Zolo. And Per, I don't think we've met Per. I don't know, Per Damien. I don't know if you can hear us. Can you hear us okay, Per? Go ahead. Well, perhaps not connected. Okay, Natalie, very good. I'd like to thank you for the presentation, and we look forward to hearing more from you in the future. And to everyone, be prepared for online conferencing, because we're going to see a lot more, Marco, of online conferences, because obviously neurosurgeons can't travel now, and it's going to be getting worse. Who knows how long it's going to last. The good news is we're equipped to handle it education-wise, because we know the platform, we know how to arrange conferences. So Zolo, it shouldn't be a hard thing to do to put together conferences for the next, who knows how many months it's going to be, where people are restricted from traveling, not only in between countries, but possibly between buildings. I don't know how it's going to get. So anyways, we'll end this chat now. Thank you everyone for coming.